Hello everyone, welcome to ENT Mastery course. I'm Dr. Mehak, and in this presentation I'm going to talk about tests in allergy diagnosis. So basically we are going to discuss about the tests that we use in allergies, okay? So this is a very important presentation for you guys, especially the skin prick test is very important in this presentation, okay? So it is important in every aspect, whether it is about practicals, whether it is about theory, or whether if you are going for any competitive exams. Okay, this is a very upcoming and very interesting topic. Of even if you are planning to even if you're planning to practice as a allergy specialist, then also you should be very well versed with this presentation. Okay, so let's start this presentation. In this presentation I'll be talking about selecting allergens for testing. Okay, then I'm going to talk about skin testing. In testing we have skin prick test, intradermal testing, and blended skin testing techniques. Okay, then I'm going to talk about serum specific IgE measurement, then total IgE. Then I'll talk about basophil activation test, then component resolve diagnosis, that is CRD, then allergen challenge testing, then nasal biopsy and cytology, and there are some name non-validated tests for allergy. Okay, so to make this presentation I have referred multiple journals, and otherwise I have from your standard textbook I have referred Scott Brown and Cummings mainly, and also a little bit of Ballingers and Sattloff. Okay, so let's start this presentation. So let's start. So basically allergy diagnosis includes an assessment of clinical presentations followed by some tests, and they are in vivo and in vitro tests. Okay, now demonstration of sensitization to a suspected allergen, that is the presence of allergen specific IgE, is required for diagnosis. But not all the individuals, see, having allergies is different, but having sensitization to something is different. So not all the sensitized individuals are clinically allergic. Therefore, confirmation of allergy diagnosis requires either a convincing relevant history or a reproducible allergic phenomena by a controlled challenge test, that is a provocation test. We'll talk about it. Hence, the challenge test is accepted as a gold standard test in allergy diagnosis. Okay, remember this point. And now moving on to selecting allergens for testing. Okay, so basically inhalant allergens are generally divided into groups by source. Okay, the main groups are pollen, molds, epidermals, and arthropods. Now allergen qualities that affect their selection in testing include cross reactivity, potency, and abundance. What I mean is, like, the example of cross reactivity is demonstrated in pollens. So a sensitized person who tests positive for one pollen will reliably test positive for the other, as they bind the same serum IgE site that can be proved through competitive inhibition. Now, as such, it is not necessary to test an individual for both. Now, potency or antigenicity refers to the strength of reaction produced by the exposure. Okay, now, for example, the grass pollens are less abundant than tree pollen, but they are more potent. Okay, now generally if a sensitized person were tested to an equal amount of grass and tree pollen, they would likely to develop larger reaction from grass pollen. That means grass pollen is more potent. Similarly, pine pollen is an example of a pollen that can be very abundant but not very potent, because it tends to cause less symptoms. Okay, now however, even a minute quantities of cat dander can elicit excessive symptoms because it is highly potent. Pollen allergens are subdivided into pollen allergen, if we talk about pollen allergens, they are subdivided into trees, grasses, and weeds. Okay, now allergenic pollens are typically spread by wind rather than by insects. What insects I mean is bees, and they are called as anemophilous. Okay, Now, pollens are relatively large airborne particles, and because they are large in size, they tend to cause more impact on nose and conjunctiva rather than lower airways, because the larger particles cannot reach till lower airways. Okay, because of this, pollens tend to clinically exacerbate allergic rhinitis and conjunctivitis, while smaller mite, danders, and mold allergens play a larger role in causing lower respiratory tract symptoms like asthma. Okay, now pollen allergy tends to be intermittent or seasonal. Now, tree pollens tend to be released in spring, and abundance causes significant clinical allergy. Common allergic trees include oak, cedar, and birch. Grass pollen exhibit high potency and high cross reactivity, and grass pollens are mainly more prevalent in summers. If we talk about wheat pollen, they are present in summer and they fall in summer. Okay, and ragweed is a potent, abundant, and widely distributed pollen that tends to released in late summer and fall early. Wheat pollens have less cross reactivity than grass and vary significantly by region. However, the actual presence of any pollen in the air depends on the flowering seasons of the plant in the picture. Now, selecting appropriate allergens based on their prevalence in the area where the patient lives is very important, as not all the allergens are found everywhere. Okay, especially, and this is especially very important when we talk about pollens. Okay. Now, if we talk about arthropod allergy, they mostly are because of dust mites and cockroaches. Okay. Now, dust mite allergy is very common. Okay, it is very common, and even in Western countries and those with impeccable level of cleanliness, even they can get dust mite allergy. Now, they are found in high. So, how to prevent dust mite allergy, that itself can come, as a question for you guys, and that is a huge long topic. Okay, but anyways, let's not talk about it now. They are found in high quantity in pillows, carpets, mattresses, but also they are found in furniture as well. They are microscopic and they do not cause symptoms in non-sensitized individuals. Okay, now there are two common dust mite species in United States. We are talking about temperate areas. They are Dermatophagoids farini and Dermatophagoids ternicinus. Okay, uh, Teronicinus. Okay. Now, this Blomia tropicalis is basically found in tropical climates, that is Indian subcontinents. Okay. Now, see, this is the flowchart that is given in Scott Brown 8th edition. Okay, but it is not important for you guys because we are going to talk much more about allergy here. But anyways, I'll just discuss. So what it says is, if the patient is having any allergy history or symptom like asthma, rhinitis, or eczema, I mean, you go for allergy history first. Okay, if it is negative, you go for SPT or IgE, and if it is again negative, you go for non-allergy specific treatment. If it is positive, you take allergy history again, and then if it is positive, then you give allergy specific treatment. Okay, now the other thing is, if the allergy history is positive, you do SPT IgE. If it is positive, you go for allergy specific treatment. If it is negative, then you take allergy history again, and the same thing. But we are going to talk about something here that is more important, that is called as top down or bottom up approach. This is important, and this is what we follow these days. So what it means is, now today most widely applied diagnostic approach starts with the patient's clinical history. We all know that, and that is what we do. We ask history first, followed by, so in allergy it is followed by SPT or extract based IgE testing, and then we use CRD. So CRD is a higher test, we'll talk about it, and then we go for CRD only as an additional source of information. Okay, this is what we follow generally. Now, after doing so much, when do we do CRD? Now, CRD is the latest technique where you can get very good knowledge of all the allergens and the proteins to that level, what very specific proteins, about very specific proteins that are present in the allergens. Okay, so what is this top down approach? So in top down approach, we take history, we do SPT or any other test, and then we do CRD. Okay, so what are we doing? So when CRD is performed in this case, it is usually through a single plex assay, and the clinicians decide which allergen component should specifically be looked at. Okay, so what it means is we are taking history, we have done SPT, everything. Now we are doing CRD, so we know what we have to look at. Okay, so we do very single plex assay CRD. Okay, this is known as top-down diagnostic approach. In contrast, the bottom-up approach starts with the detailed information that CRD provides and moves from that to the clinical history. Okay, to allow a comprehensive evaluation of allergic disorder. Okay, so what we are doing in bottom-up approach, we are going from CRD to the clinical history. So in CRD, we get very specific information. Oh, the individual might be sensitized to this thing. So we go for very specific history that way. Okay. So in bottoms up, we are seeing what patient could be allergic to and what he is sensitized to very specifically. Like certain pollens are present in fruits, so in flowers and everything, so the patient is eating also, then also it's coming positive. So basically, to come to any conclusion in CRD, a very good allergy specialist. Okay, so in CRD we are knowing all these things, and then we are taking relevant clinical history. That is bottoms up approach. Okay, so now it is a debate about whether to follow this top down approach or bottom up approach. So supporters of this approach, that is the supporters of bottoms up approach, praise the global assessment of patients IgE repertoire, because I mean patients IgE collection. Repertoire means collection, because even a positive results without current clinical symptoms may predict a future allergic manifestation. Okay, but however, this approach is largely debated as it may lead to unnecessary avoidance measure. For example, simply you might tell patients that you should avoid this fruit because you may be allergic to that. Okay, that could even worsen the patient's sensitization state and prevent tolerance induction mediated by natural allergen exposure. Like what hygiene hypothesis says, that if you keep a baby in a very hygienic environment, he might develop more allergy. Similar is with this. Okay, if you take a lot of precautions, then also it's a problem. So this is the flow chart. This I have taken from IACI, and okay, so this explains the top down approach, that you take clinical history, if the patient is having, you come to a diagnosis, you think of a diagnosis. If a patient is having seasonal allergic rhinitis or perennial or asthma or whatever, okay, then or oral allergy syndromes, fine. So like in CRD, you can find out lot of oral allergy syndromes. Okay, patient might be unaware of that. Like I told, a pollen might be present in a fruit also, and patient might be allergic to that pollen. So such things are very good in CRD. So okay, so then after doing these things, you do a proper test, SPT and all that, whatever suits, whatever the you decide, and then you go for particular CRD. Okay, now and then you come to the diagnosis, and bottoms up is you do a allergen microarray, then you see for a particular tropomycins or proteins. Okay, tropomycins are seen in various cockroaches, or mite specific allergens, or CCD is cross-reactive carbohydrate determinant. Okay, then you go for a specific clinical history, then you decide for a diagnosis. Okay, now there is something called as combined U-shape approach, that first you do your clinical history, and then you do CRD, and then again you assess CRD, and then you go up. Okay, So you basically combine both these approaches, okay, that is combine you. So talking about the skin testing, okay, see, this is not skin prick testing, so we are talking about skin testing. So what happens here is when a specific allergen is introduced into a skin, cross-linking of this Fc epsilon Ri. So this particular receptor is a high affinity IgE receptor, which is specific for allergy, okay. So cross-linking of this receptor occurs if allergen-specific IgEs are present in sufficient quantities on the cutaneous mast cells, okay. Then following this transient, okay, remember transient wheel and flare response develop as a result of mast cell activation and release of mediators, okay. So the skin testing is widely used in diagnosis of variety of IgE mediated allergies, and it should be performed by allergy expert because there is a small but definite risk of systemic allergic reactions. Okay, so there will be risk of anaphylaxis. The two major methods of skin testing are skin prick test, that is SPT, and intradermal test. The short form is IDT. Okay, these two short forms are important. Now first, let's talk about skin prick test. Now skin prick test can come as a separate question for you guys, okay. Now after cleaning with a 70% alcohol solution, 1:10 or 1:20 weight by volume allergen extract solution are placed at least 2 centimeter apart, okay, this is important. So these allergen extracts are kept 2 centimeter apart at the volar surface of the forearm or upper back. It is mainly done on the forearm like this, okay. This is the different test. This is the skin prick test, okay. So the gap should be at least 2 centimeters so that you can see the response properly, okay. So a separate commercially available test device, that is Lancet, is used to prick through each droplet of allergen, okay, and the depth should be around 1 mm of each prick. Now there is something called as prick by prick test. Okay, this is a skin prick test when a fresh fruit is used as a source of allergen. This is a prick by prick testing. Why it is done? Suppose a patient says that when I eat banana, I get allergies, okay, but you don't have allergens for banana, you don't have allergens for kiwi, okay, and but patient is very specifically telling that when I eat kiwi, I get these, some oral rashes or skin rashes. So you take a prick from the fruit and then you prick the skin, okay. You take and like that you do, and you see for a response. That is called as prick by prick test, okay. The test device is used to prick the food initially and then the patient's skin. So now see, this is another thing that is given in Sattleoff, but I have not seen. So there is something called as multiple head applicator where you can take multiple allergens and do the test, but just remember that something like this is also there, okay. Then we have this histamine. So histamine dichloride, that is taken 10 mg per ml, is used as a positive control, and a negative control of dilute and identical to that of allergen extracts. So the negative control will usually be glycerinated saline or normal saline, okay. That should be always included in tests. So whenever you do a test, there will be a positive control and negative control. See, this is a positive control and a negative control, okay. So the positive and negative controls acts as a validator of the test. Everyone must show a wheel of equal to or more than 3 mm for histamine, otherwise the test is invalid. This is important. So the positive control should be always equal to or more than 3 mm. If it is not, then the test is invalid. That means either patient has taken something that is suppressing the histamine. Patient should always be giving positivity or reaction to histamine. If he is not giving, that means either he has taken something in which we cannot do skin prick test, like either patient is on antihistamine or antidepressant. So there are certain medications that needs to be stopped before skin prick test, okay. So histamine should be this much. Now any wheal Any wheel of size 3 mm more than the wheel of the negative control is considered positive for the test. Another way of interpreting is that the wheel of 3 mm with the flare after 15 to 20 minutes is considered positive, and that is the presence of sensitization. Now what I mean by this, so this line, okay, this line is given in your standard books. That means that if the wheel of, when you give an allergen here, okay, these are the allergens, and if this wheel is more than or equal to 3 mm along with the flare after 15 to 20 minutes of giving the allergen, then the test is considered positive. This is as per all the standard textbooks. Okay, now but what we see in our practice is any wheel of size 3 mm or more than the wheel of negative control, okay, is considered positive. Now what happens, all the time you will not get a wheel of more than 3 mm, okay. There might be something wrong after 15 to 20 minutes. It is not so, okay. So the test is even considered positive if the size of wheel is 3 mm or more than the wheel of negative control. What happens is sometimes the wheel of negative control itself might be slightly bigger, okay, in certain patients. So if this is more than 3, if this itself is more than 3 mm, the negative control is more than 3 mm, okay, and if here you are getting it as 6 mm, then also it is considered as positive, okay. So this is what I mean here. Now many studies have demonstrated that SPT to be effective in diagnosis of AR, with sensitivity reported as 80 to 100% range and specificity around 90 to 90%, okay. Now talking about the indications of skin testing, first is aeroallergy, that is rhinitis, allergic asthma. For that it is well validated. For food allergies like allergies to nut, milk and egg, that for that also it is well validated. For drug allergy like penicillin, it is often used. For venom allergy, like wasp and bee, it is diagnostic test of choice. And for latex allergy also it is a diagnostic test of choice, okay. Now cautious and contraindications of skin testing. So the high risk patients, okay, in high risk patients, that means poorly controlled asthma, clinical histories of severe reactions to minute amounts of allergen also, then significant cardiovascular disease such as CHD and coronary heart disease or cardiac arrhythmias. Then in recent anaphylaxis, so the skin can render temporary non-reactive after anaphylaxis of 2 to 4 weeks, okay. Then there are certain interfering medications that is listed separately. I'll talk about those, that is important. Then unsuitable skin conditions like dermatographism, urticaria, dermatitis, cutaneous mastocytosis. Then it is not unknown for allergic individuals to have small reaction from negative controls, possibly due to glycerin, okay. Now the medications, so many drugs can interfere with skin testing and should be stopped prior to skin testing, okay. For example, antihistamines, it's very important to take this history, okay, before doing SPT. So antihistamines should be stopped 3 days for non-selective short acting and at least 7 days prior to doing SPT for long acting, that is long acting antihistamines like cetirizine, okay. But if patient has time, better to stop all of, take a 7 days good gap, okay. Now H2 receptor antagonist should be stopped 48 hours. Then chronic or relatively high dose of systemic corticosteroids like more than 20 milligram per day may partially suppress skin testing. Omalizumab may depress skin reactivity for up to 6 months or longer. Tricyclic antidepressants and phenothiazines may decrease skin reactivity for up to 2 weeks. Now, other drugs may affect skin testing. So, some muscle relaxants and anti-emetic drugs with antihistamine action may affect skin testing. Oral and intranasal corticosteroids have not been shown to negatively affect SPT. However, topical steroids applied to skin have been shown to affect healing response at the site of application. Okay. Now, in physiologic factors, extreme age may reduce skin reactivity. So, forearms may produce smaller wheals than skin of the back. Then technical factors, the quality of allergenic extracts, testing devices and techniques. So the major inhalant allergen should be well characterized and standardized, except are basically more characterized and standardized except for molds. Okay. Now, although extracts of milk, eggs, peanuts, soy, fish, shellfish, and tree nuts are reliable, the most commercially available food extracts are not standardized. For example, commercial extracts of fruits and vegetables. Okay. Then we have allergen. It depends on allergen preparation also. So allergen extracts used in current clinical practice are obtained mainly from natural sources, and there is immense variability in commercial preparation of these products, like season, growth conditions, genetic factors between geographic regions, etc. Okay. Now these are the list of medications that may affect skin testing. Okay. So, see, I told you about antihistamine. So, these are basically, you don't have to mug up this list, but this is what is followed by a clinician. So, if you are practicing allergies and if you do a skin prick test regularly, then you should have this list. Okay. So, of course, antihistamines have to be stopped, and you don't have to take for at least 5 days. And there are certain medications that you have to stop for more than 5 days. Okay, to be on safer side, tell them to stop antihistamines a week prior to the test. Okay, so these are the first generation antihistamines, and these are again first generation antihistamines. Then these are second generation antihistamines. Okay, so and these nose sprays and eye drops should also be stopped. Okay, then we have these other antihistamines that have to be stopped, like ranitidine also should be stopped 1 day prior. Fine. So then tricyclic antidepressant, but you should consult with the doctor who prescribed them, and they should be at least stopped 11 days prior to the test. Okay, certain medications have to be stopped for more than 11 days. Now, see, like imipramine should be stopped for at least 14 days. Now, then we have benzodiazepine that has to be stopped at least 7 days prior to the test. Then atypical antidepressants or sedatives that have to be stopped for at least 5 days prior to the test. And then these beta adrenergic blocking agent or beta blockers that is basically given for controlling the blood pressure. So they also should be given should not be given before the test 5 days prior. Why? Because the skin prick test will get affected, because if at all the patient has anaphylaxis and if you're giving adrenaline, so one of the side effect of skin prick test is anaphylaxis, and to treat anaphylaxis you have to be ready with the adrenal ampule. So if you are giving that, then controlling BP becomes very difficult if the patient is on beta blockers. Okay, so that's why it is stopped. But again, the doctor who prescribed, he should give a replacement medication. Okay, instead of beta blocker, he should subscribe something else. Then there are herbal supplements that you need not take 7 days before allergy testing. So these are the things. And then medications that you can take before allergy testing. So you need not stop all the nasal sprays. So certain nasal sprays that were listed before, that only should be stopped. Steroid nasal sprays can be given. Then eye drops, these all eye drops, and proton pump inhibitor can be given very well. And then This serotonin norepinephrine reuptake inhibitors can be given, so they are also antidepressants. So these antidepressants need not be stopped. Okay, then others, the antibiotics need not be stopped. This is important. Okay, so and also remember, do not stop taking your asthma medication without the doctor's advice. Now talking about the standardization of allergens. So preparation of high quality allergen extract is essential for diagnosis of immunotherapy of allergic disorders. Okay, so biological standardization of allergen extract concerns determination of allergen unit, development of reference material, and measurement of overall IgE binding capacity of the allergen extract. Okay, so recently the quantification of individual allergens has been the main focus of allergen standardization, because the allergenicity of most allergen extracts is known to be mainly dependent on the content of small number of allergen molecules. Okay, now so the use of standardized allergen increase the validity of SPT. Now the use of minute concentration of standardized allergens reduces the risk of anaphylaxis. Okay, so but in recent years various companies have successfully standardized different allergens. In earlier times, due to lack of standardization, anaphylactic reactions were more in SPT. Now, the Center of Biologics Evaluation and Research in US Food and Drug Administration maintains 19 US reference standards for potency, in which 6 are Hymenoptera venens, 2 dust mites, 2 cat dander extracts, and 1 short ragweed pollen and 8 grass pollens were considered. Okay. Now, talking about the risk of anaphylaxis. Okay, now risk of anaphylaxis in SPT and various other skin tests are, so this is what is given in Scott Brown. So the clear data about this is not given anywhere. So as per various studies, the potential systemic reactions are reported to be 33 in 1 lakh SPTs and 0.5% in prick by prick test. Okay, and which was done in infants using fresh foods, and the potential systemic reaction is 0.5%, and all fatalities have been reported in intradermal test, which I'll be talking about, without prior SPT. So intradermal test can be done in two ways, with SPT or without SPT. Okay, so if you do intradermal test without SPT, the potential of systemic reactions is around 0.5%. Now, appropriate training and full emergency equipments and medications are essential when skin testing is used. Now, advantages over other tests. So, less expensive than serum testing, and that it is this SPT is less expensive than serum testing and safer than intradermal testing, because the risk of anaphylaxis is low and there have been no reported deaths. Okay, it is also better tolerated in pediatric population compared to intradermal testing, given the ability to apply multiple antigens at a time along with minimal discomfort. Now there are reports available within minutes of testing. That is the advantage of SPT, and patient himself is seeing what is getting done, so it is more convincing for patient. Okay, because the reaction occurs live and the patient can see it. It checks for bound as well as free IgE and antibodies, and that is the advantage of all the provocation tests. Now, what are the disadvantages of SPT? First is the pain. Lot of patients are scared of the pain. They think that if they prick, the pain will be more. Okay, so the pain endured during multiple pricks may discourage some patients from going for it. Then there is a risk of anaphylaxis, even though it is negligible. We need to take informed consent from the patient. This is very, very important. The consent form should be there when you are doing SPT. Okay, now the marks after the pricks may linger for a couple of days. Then diligent pricking of various allergens take time. The test cannot be done if the patient have taken a certain medications. Now some patients cannot stop anti-allergies and antidepressants. Okay, now then we have this intradermal testing. Now what is intradermal testing? Intradermal testing differs from SPT in that allergen extract is injected into the superficial dermis, creating a 4 mm wheal that naturally diffuses to 5 mm once the injection is complete. Okay, so it is actually little deeper. The pain is more in intradermal. It is like, if you have not experienced this test, or if you have not seen, it is like how you do give a test dose for antibiotics, right? Like that sort of a pain will be there. Whereas in skin prick test, the pricking is very superficial. It's like a ant bite. Okay, I mean, I don't, it's like very less. Okay, now as with SPT, positive and negative controls are also applied in intradermal test. Here, after 10 minutes, the wheel is examined and measured. Now, the wheel measuring more than 7 mm and at least 2 mm wider than the negative control is considered positive. Okay, here. Now, one advantage of intradermal testing is the ability to perform the test using series of dilution of a particular allergen. This is very important here, that you dilute the allergen. You can use various dilution and you can do testing. Okay, that is so when you dilute the allergen, it is called as intradermal dilutional testing. Okay, so that time it is called as intradermal dilutional testing, that can help to establish appropriate starting point of allergen immunotherapy. Why are we diluting the allergen? Because we'll know, okay, at this point the patient is showing sensitivity, so at this point we can give immunotherapy. What is immunotherapy? Basically, we are giving the same allergen to the patient so that he gets, immune to those things, but to whichever allergen he is sensitive right now. Okay, so whenever we see, so what happens here? So that in dilutional testing, the test begins with dilute allergens followed by increasing concentrated applications of allergen until a positive wheel is encountered. Okay, and when you see that positive wheel, that is called as end point. That is basically from where you have to start the immunotherapy. At that dosage, you have to start the immunotherapy, and the next higher concentration produces a confirmatory wheel of 2 mm larger than the endpoint. So that is known as the confirmatory. That is not relevant. Okay, now some authors have advocated the use of intradermal testing to increase sensitivity of SPT. However, studies investigating this have shown that the additional intradermal testing to SPT resulted in only marginal increase in sensitivity. Okay, certain studies have says that if you do both the tests together, SPT as well as IDT, that will improve the sensitivity. Okay, but certain studies says that it has only marginally increased the sensitivity. Okay. Now, additionally, other authors have suggested that the positive intradermal test in setting of negative SPT may represent false positive. Now, these findings suggest that the addition of intradermal testing to SPT does not significantly improve the diagnosis of allergy. Okay. Now, there is something called as blended skin testing techniques. Okay, that actually is SPT plus IDT. So that combines both SPT and intradermal testing techniques. Okay. So this is basically known as, so there are various methods of doing blended skin testing, but mainly it is called as modified quantitative testing or MQT. Okay. Now compared to IDT, MQT has advantage of being less time consuming and expensive. Why it is so? Even though we are combining two techniques, it is less time consuming and less expensive. Why? Let's see. Now in terms of efficacy, MQT appears to be comparable efficacy compared to formal IDT at determining the appropriate endpoint. Endpoint means from where we have to start the immunotherapy. Okay, so why is this MQT needed? Okay, so basically skin prick testing is fast, reliable, and it requires less skill to perform, but some allergists desire more information on patient's level of sensitization, or they wish to determine an endpoint of an allergen. Okay, so this form of testing is inadequate for their needs. That's why intradermal test is needed. Now, however, intradermal dilution test is much more time consuming. It requires more skill than skin prick testing. Okay, so this is where we need a blended test. So this is where blended testing techniques come in. So that is basically the marriage of speed with additional information for those allergists who want it. Okay, so the most well-known protocol is termed here is modified quantitative testing, MQT, and it involves combining the result of skin prick testing and single intradermal testing to determine the endpoint. That is, the endpoint means a potential starting point for immunotherapy. Okay, remember we are doing here single intradermal testing. So based on skin prick testing, we dilute the allergen and do single intradermal testing. That's why it is less time consuming. Okay, if we just do IDT, it is more time consuming because we start from the beginning. Okay, so yeah, so the endpoint signifies the skin reactivity to the applied antigen on a graded scale and is considered to be the safe starting dose of application of allergy immunotherapy. Now, a question arises that who is a good candidate for this type of skin testing? The answer is anyone who is a candidate for skin prick or intradermal testing. Okay. Now, how does this test differ from skin prick testing or intradermal testing, and what is the technique that I have already told? The test is performed by placing a skin prick test for the antigen that are being tested. When based on those results, the single intradermal test of two possible dilution is placed, and based on the results of skin prick and intradermal test, the endpoint can be assigned for each antigen tested. Okay, now next is serum specific IgE measurement. So serum specific IgE measurement is also an in vitro, it is an in vitro test. So here serum IgE can be measured by serum specific IgE can be measured by sensitive immunoassays such as radioimmunoassays, enzyme immunoassays, and fluorescent immunoassays. So if you remember, we have read about these things in our microbio also. Now, what do we do in these assays? That serum is incubated with allergen of interest bound solid phase. Okay. Then IgE with specificity to allergen of interest will remain on the solid phase, which then is detected by labeled anti-IgE antibody. I'll show you the whole procedure, then you'll understand it better. So now after this, then the level of signal that is produced is proportionate to the concentration of serum IgE. Now, serum IgE can be falsely elevated when the total IgE is more than 1000 kilounit per liter due to non-specific binding. Okay. Now, solid phase varies in different assay system. See, there are various companies that make these assay system which has solid phase where the allergens will go and bind. Okay, I'll talk about it. So for example, this is by Immunocap company. So there is this solid phase here, okay, that is cellulose polymer. Okay, and so here the allergen component with different binding epitopes will be there, and they are CNBR activated. CNBR is cyanogen bromide activated cellulose coated with allergen component. Okay, now these allergen component epitopes will react with IgE in patient serum. Okay, so these are the IgE that are present in patient serum. When you put the serum, they will react with these epitopes, and then what we do, we put enzyme label anti-IgE that reacts with these forms which are bound IgE forms. Okay, and because they are enzyme labeled, so they will react with the substrate, and they will produce some kind of fluorescence. Depends on what immunoassays we are using, whether we are using radio immunoassays or enzyme immunoassay or fluorescent immunoassays. So based on this, we'll suppose if it is fluorescent immunoassays, it'll have this fluorescence intensity, and that will be equal to the concentration of this reaction that is happening here. Okay, so that is what I meant here. So the solid phase, this solid phase is varies from company to company. Okay, for example, the immunocap, which is by Fadia, that has cellulose sponge matrix in form of in form of a small cap. Then we have this, so this is the most popular company. Okay, then we have Imulite system that has evidence solid phase, and then we have HY Tech 288 system that has cellulose wafer as solid uh, as solid phase. Okay, now similarly, reagents used in different system vary. Therefore, serum IgE results from different systems are not interchangeable. Now the immunocap system is currently most widely used serum IgE measurement in UK. Now the process is as follows. Okay, so what we do is the allergens are bound to a substrate to which the patient serum is added. Okay, then serum IgE in patient serum then binds to the allergen on the substrate, like I told you here. The excessive serum is washed off with it, and any unbound IgE also gets washed off. The non-human anti-IgE antibody tagged with the marker are subsequently added, and that binds to any corresponding serum IgE that is immobilized. This step. Okay. Here also excessive anti-IgE antibodies are then washed off, and the autoanalyzer reads the intensity of radioactive or chemiluminescence or colorimetric or fluorometric reaction. Now the indications of this serum specific IgE is when there is a high risk of anaphylaxis where you cannot use SPT, and when the use of medications that can cause interference with SPT, and when there is a skin lesion unsuitable for SPT, and in small children. The level of serum IgE is not directly correlated with the severity of allergy. Also, the allergen extract is a mixture of proteins here, okay, from allergen protein components from allergen source. Okay, these are the indications of serum specific IgE. Only these are the indications. Okay, now actually there is more recently component resolved diagnostics, that is CRD, is used for detecting serum IgE to allergen components. So this is slightly that is more better than this. Okay, now talking about the advantages of this serum specific IgE test is that the safety profile is superior to skin testing because there is no risk of anaphylaxis. The testing is not affected by skin conditions such as dermatographisms or eczema, and patients are not required to stop any medications prior to testing. It can be done on patients who have taken anti-allergics and antidepressants, and the patient's acceptance is higher as only one single prick is involved in contrast to multiple pricks that is done in provocative tests like SPT and IDD. Now the disadvantages here are increased cost associated with in vitro testing. Now, so these are the cost is almost similar nowadays, but this is what is given in the books. Longer wait time to obtain results, higher false positive, and the results from different lab systems may vary. Okay, now talking about the total IgE. Okay, now total IgE is elevated in atopic conditions such as atopic dermatitis, atopic asthma, allergic fungal sinusitis, and allergic rhinitis. So total IgE is basically irrelevant for diagnosing allergies. Okay, I mean allergic rhinitis. But recently it has been proposed that the ratio of serum IgE to total IgE may be clinically relevant. So the ratio is important. So higher serum IgE and total IgE ratios were associated with more severe allergic system. symptoms, okay, as per some studies. So specifically, high serum IgE and total IgE ratios were seen in food and venom allergy, where systemic reactions are more common than most inhalant allergies. And it is not a very specific test and may be raised in worm infestation also. Some research says that Indians generally have higher average total IgE than Western populations. Okay, now talking about basophil activation test. So next is basophil activation test. So this is an in vitro study of peripheral basophil response to stimuli. So this test uses whole blood, and therefore it is more accessible than mast cells to study IgE mediated response in allergic reaction. So what it is done, it can be done assessed mainly by two methods. First is the measurement of mediator release like histamine, or detecting the increase of cell surface molecule or newly expressed cell surface molecule. So what we can do, either we can detect the mediator that is released by the cell, that is histamine, or we can detect the cell surface molecules that are present on the basophils. Okay, and these cell surface molecules are CD63, CD69 and CD203C. Okay, now so what we are doing is the whole blood of the patient is incubated with the allergen of interest. Then what happens? The basophils are stimulated due to cross-linking of specific IgE, Fc, epsilon, Ri on basophil. Okay. When that happens, then the degranulation of basophils occurs, and because of degranulation, there is expression of molecules that we discussed here, like CD63 on basophil cell surface, and that particular molecule, okay, these molecules are detected by cytometry. So this is how we detect the molecules. The next way is to determine histamine. So what happens is, in an unstimulated phase, these molecules, the molecules that I spoke, these molecules are actually anchored by a membrane of intracellular basophil granules, and these granules have histamines. But when the degranulation occurs, these molecules also gets expressed and histamine also gets released. So either you can check these molecules by flow cytometry, or you can determine the histamine that are getting released. Okay, so that is what we do in this test. So BAT has been used to assess allergic response for allergens that are not commercially available for serum IgE measurements, and that includes certain aeroallergens, drugs, venom or food allergens. Now the limitation of BAT is that it is not well standardized. Like for example, for allergen concentration, it requires fresh sample and highly skilled technician. Interpretation of test demands a highly trained immunologist or allergist, given there is a concern about false positive related SD63 expressing platelet. Therefore, BAT is currently unavailable in limited numbers of diagnostic laboratories. Okay, now next is component resolved diagnosis. So component resolved diagnosis, CRD, is an in vitro technique to detect allergen specific IgE, and CRD offers the advantage of testing for IgE reactivity at the individual protein level. Okay, so this is also detecting very specific protein in specific protein in allergen. This increased level of diagnostic accuracy actually offers some advantage. Now, for example, what I'm saying is, for example, this CAN F1 and CAN F2 and CAN F5 are all proteins that are related to dog allergy. But it is seen that up to 38% of dog allergic patients are monosensitized to CAN F5. Okay, which means that they are able to tolerate female dogs. For example, if the patient is sensitized to CAN F protein, they cannot keep a male dog, but they can keep female dog if they are dog lovers. Okay, so that is why this amount of specificity is needed in allergy testing. So this distinction would not be possible with traditional testing techniques using whole antigen. Okay. Now, CRD can also help to distinguish cross-reactivity from true co-sensitization and may help better predict the long-term course of allergy in sensitized patients. For example, in one of the study, it has showed that the childhood sensitization to specific cat or dog molecule, for example, FELD1 or CAN-F1, or polysensitization to cat and dog molecule was better predictor of allergy in adolescents than sensitization to cat and dog extract. Okay, so very specifically, if you give immunotherapy or sensitized, then it is better. See, if a randomly, if a child is allergic to cat and dog both, and if you give immunotherapy for both, that is not right. So allergies to certain protein components may not be treatable with allergen immunotherapy. That also we should know, that there are certain components that cannot be treated and patients have to be careful about it. So this can be diagnosed prior to initiating allergic immunotherapy by CRD. That is not possible by other methods. So now talking about allergen challenge testing. So see, what are the challenge testing? Like SPD is also a challenge testing. Okay, wherever you give allergen and you see a response, that is a challenge testing. Okay, now as per your standard books, so any like these sort of challenge testing are the gold standard tests. Okay, I'm not talking about nasal provocation test, but yeah, SPT is a gold standard test for allergies. So like that. Okay, so there are many challenge testing, like I told you, wherever you give allergens and you see response, that is a challenge test. So challenge testing basically involves locally applying the allergen to the target organ and assessing for the response. For example, nasal provocation test, that is used for diagnosis of allergic rhinitis. So here the allergen is applied using variety of different devices, including pipettes, droppers, sprays, or impregnated discs. Okay, like in SPT we are using Lancet. Fine. So the response is measured using a combination of subjective symptom scores and objective measures such as acoustic rhinometry, rhinomanometry, peak inspiratory flow, etc. Okay. So now basically NPT can be very useful in settings of LAR. Okay, where your SPT will be negative, but NPT, that is nasal provocation test, will be positive. LAR is what? Local allergic rhinitis. Okay. So NPT is very useful in setting of LAR or other scenarios where traditional allergy testing is negative despite high suspicion of allergy. Okay, now there are significant downwards to SPT, however, which limits its use in clinical practice. Now, since the goal of NPT is to elicit AR symptoms, it is very unpleasant for patients, and additionally, the technique itself has not been well standardized, and therefore the results are often difficult to interpret. And there are high risk of anaphylaxis in NPT. Now, moving on to the next test, that is nasal biopsy and cytology. Now it is a traditional method, and it has some limited utility, mainly when alternative diagnosis such as granulomatous nasal conditions are being considered. Okay, nasal cytology involves the collection and sampling of surface cells in the nasal mucosa. Now, although generally not necessary in diagnosis of allergic rhinitis, nasal cytology findings can help to distinguish between various forms of rhinitis, including allergic rhinitis, non-allergic rhinitis with eosinophilia syndrome, and idiopathic rhinitis. So, AR is characterized by large amounts of eosinophils, mast cells, and basophils. Okay. Now, moving on to the non-validated tests. So these are the tests that are given in Scott Brown. So the following tests have not been validated to be used in allergic diagnosis. Okay, that is Vega test, kind senology, hair analysis, provocation neutralization test, then iridology, leukocytotoxic testing, and auriculocardiac reflex. Okay. So that's all guys about this presentation. Okay, I hope you have liked this presentation, and please let me know if I have missed something. See, there are plenty of things that can be discussed about skin prick test, and also like I told you about the approaches for skin prick testing, okay, that I have not discussed in detail because I feel that's not relevant for you guys at this point. But if you feel that I have to discuss more and it has come in your exams, please let me know. I will definitely make a separate presentation for that. And also, I forgot to mention in the beginning, I have referred Bailey's also for to make this presentation, okay? So that's all about this presentation. Thanks a lot.